This is Rafay Sabzwari, second-year cardiology fellow at Lehigh Valley Health Network at ACC 19, and today I have the pleasure of having Dr. Vikas Aggarwal with us. He's an interventional cardiologist at University of Michigan. Welcome, Dr. Aggarwal. Thank you for being with us. So I would like to just begin, since you've just been a fit recently and then you've transitioned into being an attending and now an interventional cardiologist who's very actively involved in an academic position, of how this transition has been and what are the highlights that you would like to share of that journey, especially with our fits who are trying to pursue interventional cardiology.
Excellent question. So as you are graduating from your interventional training programs, so we are all faced with this decision / dilemma. So with our careers, we all want to do a lot of different clinical interventional procedures, and we want to take care of patients with coronary disease, valvular heart disease, vascular disease, but you only have 5 days in a week and 8 to 10 hours of work time per day. You have to pick and choose what you want to do. The one most important thing I can tell you is take your time and find where your heart is. Do what makes you most happy that day. There is no substitute for that.
Right.
Everybody who graduates also needs to know the day you graduate, it doesn't mean you know everything that day. From a fellow in training to an interventional cardiologist or an academic cardiologist or in private practice, you have to continue to learn. In my mind, your most advanced aggressive learning curve is going to be in your first 6 months after you have graduated. You should not shy away from seeking opinion and advice from senior people at whichever practice or location you end up being. We are confident, smart, intelligent people. That's why we go through all this training and we get to where we get to, but it's very important to have that humility and to maintain that humility. You don't want to be humbled by bad outcomes. You want to start humble and you want to build on that humility and become more and more confident. That's what I can tell you, and then what makes you most happy? Academia, non-academia, coronary, vascular, peripheral, structural. So follow your heart, okay?
And this, at the ACC 19, we just came across this late-breaking clinical trial, the AUGUSTUS trial. So I would like your thoughts and opinion and any take-home message, especially for our fits, of what would be the highlights from your end.
So excellent study. It's a study that was needed. It's a study that extends what we already know about direct oral anticoagulants in this patient population who's needing antiplatelet therapy for their coronary intervention and then anticoagulation therapy for stroke prophylaxis and atrial fibrillation. Pioneer AFPACI informed that monotherapy with thienopyridine, clopidogrel, along with rivaroxaban was safe and effective in preventing strokes as well as other major adverse cardiac events in these patients who were getting PCI. Having a trial now, which is a 2x2, unique factorial design, answering a comparative effectiveness of warfarin versus a DOAC like apixaban, as well as aspirin versus placebo in these patients with a background of thienopyridine monotherapy further consolidates. And I now think we have the evidence to bring this to our practice uniformly. So I feel comfortable using thienopyridine monotherapy with So with the direct oral anticoagulant, if I put in a coronary stent and my patient has AFib and needs stroke prophylaxis. Hope that helps.
Yes, definitely. I think that's definitely a good take-home message. And with that, I would like to thank you, Dr. Aggarwal, for being with us. And for more videos like this, please visit youtube.com/fitsonthego. Thank you.